الرحيم. نبدو طبعا المحاضرة الثانية علاج تحفظي. مرينا على المرة اللي فاتت قلنا البيولوجيكال برنسبل، طبعا حلقة خاصة بشوية باختصار البيولوجيكال برنسبل. أي حاجة لها علاقة بالبيولوجي، طبعا احنا البيولوجي يعني متعلقين بالبلب والبيدونتال ممبرين أو اللاتا أو التي ام جي also biology. There is some thing related to the occlusion. طبعا ما يتعلق بالبلب we have to protect the bulb. طبعا protection البلب طبعا we have to remove the amount of caries and we have to do the retention mean for that restoration to prevent to do the resistance and retention form for the restoration. To have to remove the caries and do the resistance and retention form for the restoration. We have no aim to cut the amount to sound tooth structure. We have to prevent cutting of the sound tooth structure. We have be more conservative as possible. This is the we have more conservative as possible. We have to only to excavate how to remove the caries and do the retention and resistance and retention, aim of retention and resistance for the restoration material, not to be dislodged and not to be the fracture, not to be fracture of the tooth. This is the aim which we do attend to do biology. So this is the when we cut through the drill the tooth, we have to cut through the parallel to the long axis of the tooth. So we have to put the bare or stone parallel to the long axis of the tooth to prevent damage to the pulp. And we make the bulbar floor flat. We are not exceeding below the dental injection 0.2 millimeter. Only if there is caries, we have to follow the caries only. The second point, we are not able to relieve any weak margin. Weak margin, we have to remove that weak margin. Weak unsupported margin with dentine, we have to remove. But when we do, for example, amalgam restoration, when we do, for example, composite restoration, we have to leave that margin and we have to reinforce the margin with adhesive composite restoration. We are not extend the cavity width, for example, buccolingually more than 1/3 or 1/4 or 1/3 of the triangular ridge, means that the ridge would run from the tip of the castle to the center grooves. And then we are not to extend mesodistally beyond the we have beyond the margin, median and distal margin ridge 2 millimeter apart, for not to weaken the marginal ridge. We have to make the floor flat to distribute the cyst and to make the force perpendicular to the floor. Okay. The second thing is we have not to put the gingival seeds more further gingivally, because when we extend more gingivally, the amount of enamel is less and the amount of dentine is less, and we have to fear from the bulbar exposure or gingival irritations. It depends on the position of the contact area buccolingually. So buccolingual contact more for the molars, it is more to the buccal. For premolars, especially for premolars, more the buccal, we have to gain for aesthetic. So we are not further extend the margin beyond the buccolingual line angle, of course, buccolingual line, buccoaxial line angle for aesthetic reason. Only if there is only if the margin faded while the caries we have to extend. We have better to extend the margin lingually because the aesthetic is not compromised there. And the access for hygiene or for cleaning of the restoration is more bringable from the lingual. Extension of the cavity sometimes done when we do some adhesive composite restoration, buccally or lingually. There is no aim because the composite restoration will give or will solve the problem of aesthetics. In the case of biology also, we are not able to extend the cavity That what I mentioned, more than 1/4 or 1/3 of the triangular ridges, because we enter the area which concentrated for force of mastication. The force of mastication, especially the vertical forces and oblique forces, which make the restoration fracture or the tooth structure fracture. We have to make the closer contact permanently into either to the restoration, completing the restoration, or completely into the tooth structures. This is the for biology also we have to protect the bulb after cavity preparation to prevent intrusion of acids or some material inside to reach the bulb and do harm to the bulb, especially if it is composed acrylic acid, methacrylate or acrylic acid may reach the bulb, or phosphoric acid if it was do as this. And so we have to protect the bulb with the sedated base, example calcium hydroxide or zinc oxide, before we put bases, for example, zinc phosphate or zinc polycarboxylate or composite restorative materials. We only when we cutting the tooth, we have not to cut through the receded line. The receded line means the line which is away from the caries, the amount of normal structure away from the caries. When we cut through that, maybe the bulb will injure the bulb and make bulbal exposures. The second, the other things which we mentioned now, it is that we have to follow the anatomy of the tooth during cutting. So we have to follow the anatomical shape of the closer surface, and we retain the normal into the tooth into the normal morphological shape. Prevent the other thing is prevent the high contact during after finishing with the restoration. We have prevent to do high contact, means that the high closer contact or premature contact into the restoration, which make loading into the periodontia, make the tooth more mobile, or sometimes the resorption of bone, sometimes pain into the temporomandibular joint. Now we enter the next principle or fundamental of tooth preparation is the mechanical principle. Mechanical principle, it is the force related principle. It is principle related to the force. We know that in the tooth they're supported to 3 types of forces. It is compressive forces, downward movement, downward forces, it is compressive forces, downward and outward forces, which is tensile forces, sideways forces, which is the shear forces. We are afraid from that 3 forces, mainly shear and tensile forces, which is more destructive, either to break the fracture restorative material, or to break the tooth structure, or to make loading into the TMJ and make temporomandibular joint problems. So we have to blend the cavity to acquire these mechanical principles. The first mechanical principle as we mentioned, that this is the mechanical principle, force related. The mechanical principle, as we done by G.F. Black. G.F. Black, before the new cavity, it is extension for prevention for the occlusal cavity. They follow bits and fissures because the instrumentation is there is no advanced instrumentation. For example, bears and stones, it can be before it can be largest. And the other thing is, it is the motivation is low. So the case, it is when the patient when it comes into the dental clinic, so it comes with large or huge caries. So the possibility of gaining through bits and fissure, it is for the black possibility is it is aimed there. But in the advance, for example, when you do cysta classification, that I told you, it is site the sister for site. Site, I told you that it is pitch and fissure. Any pitch and fissure present in any way and any position of the tooth, it is as site 1 or site 1 or site 1. Site 2, it is the proximal median and distal for the teeth. Site 3, it is the cervical 1/3 of the teeth. And the other thing, it is the stage. Stage of the cavity, sometimes it is within the enamel, surface enamel, outer surface of enamel. In this situation, we have only to do enameloplasty or fissure sealing or something. We do it, and we are not to do cavity preparation for that situation. Sometimes we have to know there is some bits and there is invagination and make the outer outline it is less than the inner outline. We have to do to blend that wall of the bits and fissures, then the bits and fissures to make the easy to clean, easy for clean. This situation is known as enameloplasty. So sometimes the caries will extend into the middle half of the enamel, so we have to do the cavity. The cavity, sometimes it is into the enamel, or in case of adhesive frustration, we have to enter into the enamel. We are not aim to go through the dentine. If the cavity for amalgam, we have to put into the dentine slightly below the amylodentine junction, 0.2 millimeters below the amylodentine junction, for give the tree to take the aim of the tree things. It is the first thing to get the bulk for the amalgam to prevent fracture of the amalgam. The second thing, because the amalgam it is cheaper in tensile and shear, and it is rich in the compressive force. When we increase the thickness of amalgam, so we have increased the compresses, so alternately shear and tensile will improve. So we have to extend under the amylodentine junction of 0.2 millimeter to prevent fracture of the amalgam. The second thing is to be away from the amylodentine junction, which is the more sensitive area, because the odontoblastic process, it is hanging into the dentino-enamel junction to prevent the sensitivity of the dentine during cutting. The third thing is the dentine is elastic, so when the load is with the force contacting the amalgam or into the amalgam, so the elasticity of dentine will absorb that forces and will make the forces and give the more attention for the amalgam to force with the gripping action when the force is introduced. So there is expansion of the dentine, elasticity of the dentine makes expansion of the dentine, and when the force is released, there is some contraction and gripping, and the amalgam will grip it by the dentine, will increase the resistance and retention for solution. Otherwise, if we are not reaching the amylodentine, we have to do adhesive restoration, adhesive composite restoration. In some ways, we have to do adhesive composite restoration also when the caries is under the amylodentine junction. And as we know, we have to know that the bond into the enamel is more than the dentine, so adhesive restoration it is what is called in case of the caries into the enamel. We have now to go obtaining the outline form. What's the outline? We have to plan the outline. The outline form must be follow the morphological form, the morphology of the tooth. It must follow the morphology of the tooth, the occlusal surface of the tooth. We have to put the outline or to draw the outline exactly the same as the morphology of the tooth itself. Okay. We have to go through bits first with the round pair of 0.5 millimeter, so give 1 millimeter diameter. So with full length of the round pair will give 1 millimeter depth. So half of the pair will give 0.5 millimeter depth extra. So we have extending when we do 1 1/3 of the pair. So we are in 0.2 millimeter under the amyloid. So we have to start with the central pitch with round pair 1 millimeter in diameters. When we exceeding this pair inside, entering the inside into the bed, so give 1 millimeter. So 1/3 of the pair will give 0.2 millimeter or 0.2 millimeter or less. During finishing, we are of the floor, we are getting 0.2 millimeter below the amyloid junction, which is the classical outline of the cavity. The case which is beyond that limit, so we are to follow the case only. When we have to follow the case, we take a smaller pair, the pair size is smaller than the size of the lesion, to avoid cutting through the receded area of the bulb, because the bulb anatomy is the same as the outer anatomy of the tooth, or the same as the morphology of the tooth. Morphology of the bulb reflected by the morphology of the tooth. Morphology of the tooth reflected by the morphology of the bulb. So we have to obtaining the outline forms with central bit. We are introducing with pairs diameter 1 millimeters, ending into 0.2 millimeter into the amyloid junction. With the parallel direction, the cutting is perpendicular to the bulbar floor, with the parallel to the long axis of the teeth, and then we have to take the fissure pair to go through bits to fissures, so buccal fissure, lingual fissure, mesial fissure, to where the case is extended. Sometimes we do two cavities. If it is the in between there is the 0.5 millimeter or less, for example, when we do adhesive restoration, if for amalgam less 2 millimeter, we have to include this cavity two cavity into the one cavity. So, and we select smaller size cylindrical fissure pair to cut through the fissures, and we extend through the fissures, as we told before, that is not exceeding 1/4 or 1/3 the dimension of the triangular ridge from the tip to the center of the grooves. This is the situation. And also we take the pair parallel. Then we have to follow the enamel prisms, the direction of the enamel prisms. So the direction of the enamel is in the center of the bed, it is in the vertical direction. So it is slightly inward direction, makes the slight convergence from 5 to 6 degrees, which gives during the cutting or during the cavity, final cavity forms will be give the inverted truncated cone to give the retention and to resistance to the restorative materials. Then when we finish the outline, we have to do flattening with we take the converted cone pair and do the flattening of the floor. When the floor is flat, it is less stress concentration and more adhesion between the restoration and the tooth structure, because the surface area is smooth and flat and large. Okay, and the inverted truncated cone gives the retention for the dental amalgam. So this criteria we must do. So we have to bring smaller size round pair 1 millimeter in diameter, and then we have to bring cylindrical fissure pair, smaller size, to cut through buccolingually, not more than the quarter or half of the triangular ridges. Okay, this is the situation. Mesially and distally, we go through continuation for the bits and fissure, mesially and distally, and ending 2 millimeter before the mesial margin ridges, and 2 millimeter beyond the mesomargin margin and 2 millimeter beyond the distal margin region, which gives the dovetail. The dovetail also gives the retention for the restoration. Gives the retention and the resistance for restoration. The dovetail. The dovetail median and distal dovetail. Okay. We have to try to follow this. This is the cavity. According to the cavity, we have to do the design of the cavity. According to the carious lesion, we have to do the design for the cavity. And before we starting drilling the cavity, the tooth, we have to take the pitch or the occlusion, the normal occlusion which the patient is coming with. So, and we see when is the occlusal contact. These occlusal contact, if close nearby, so how to have to extend after that occlusal contact and make the contact purely into the restoration. Or if it is 2 millimeters before or apart, the occlusion will be into the tooth, either into tooth structure, complete into tooth structure, or into the restoration. 1.5 and 2 millimeter away, if it is to have to cover. If we have cutting here, there also in this situation or that situation, and we have to gain about weak cusp. This weak cusp we have to measure. If it is the diameter below of the dimension of the cusp below, it is less than the dimension. It is less than the dimension of the cusp. Dimension of the cusp into the horizontal positive direction, it is less than the occlusal, it is the vertical dimension. So we have to do the cusp capping to remove 2 millimeters of the cusp, and we cap with the materials. This is the cusp capping, 1 or 2 cusp capping. Sometimes we do cusp capping and do the preparation from the buccal side or from the lingual side to give the finish line into the buccal or lingual to resist the forces which is received by the restoration, to resolve the forces, either to cap the cusp only if it is one cusp, okay, and with 2 millimeter restoration over it, or by reducing it to 2 millimeters, and to make the vertical dimension equal to the horizontal dimension of the cusp, or if there one more than one cusp in force, we have to do the preparation into the buccal side if it is the buccal involved or the lingual involved. And we have to take their instrument into the size smaller than the side of the smaller side of the lesion. We have to follow the case to remove the case and put the retention form. If it is compromised the retention resistance form, we have to do secondary resistance and retention form as we go through and we briefly will enter into this lecture or into the other lecture. So we have to do something with lotus, growths, the locus or coffers to increase the retention and resistance force. أو بين amalgam of restoration أو amalgam to the inside the pinhole and give the more to increase into to add into the resistance and retention. This is outline form defined as the external shape of that. What I mean that outline form is the external shape of the external forms of the cavity. As we saw, this is the external. This is the outline. It is follow the morphology of the tooth. This is the upper six. This is the oblique ridges, and this is the mesial cavity, and this is the distal mesial outline, distal outline, and this is the oblique ridges. For example, if the oblique ridge it is less than 0.5 millimeter, if it is adhesive solution, we can do it. We are not to cut through the ridges because the adhesive solution will join or will tight the restoration mesial and distal will tight the ridges and prevent its fractures. If it is, for example, amalgam, we have to to do it and one cavities. So the cavity will follow the external outline of the morphology of the tooth. They take the morphology of the tooth. We are not to have to do cavity what we know, what we need. No, we do the cavity belong to morphology. If it is extended, we have to take the caries and we retain the tooth into the normal morphology. This is the cavity. It is okay. It is in the outline of the tooth. So it is, if it is mesial cavity or distal cavity, and this is the mesial will be intact. So it's separate two cavity, one mesial cavity and the distal cavity, and the rest it is more than 0.5 millimeters, so it must be leaving intact. Here, this is the caries lesion. So we have to remove. We do the outline. What depends on the caries. If the caries, so for example, if it is not reaching here, so the outline will be in here. If it is caries will be here, we have end the outline here. So we end the outline depends on the caries, depend on the extent of caries. And then we make the retention and resistance form for the restoration to make the restoration withstand the forces and it can't be distorted. Okay, so caries lesion must be included. So the caries lesion must be included in the outline. So when we remove or deroofing the cavity, so the caries lesion will be clearly seen and outlined by the normal tooth that about 0.5 millimeter or around sound tooth structures to be easily accessed to caries and remove it. This is the case into the center. So sometimes in GF black you have the extension for prevention. For that, this is, and this, to do that is as a circular outline, or it is the circular outline of this outline. It must be rounded outline or aggressive curve like this. Okay, and but in cyst classification we have to take the caries and do the aim of retention and resistance, or to put some adhesive restoration if it is the cavity is large, so we have to indirect restoration cannot work, so we have to do indirect restoration, either ceramic or gold. Okay. Also, all circumference of the caries included within the lesion. So all the caries must be included in the outline. Base and fissure groove and retentive area must be included. Sorry, base and fissure and retentive area must be included within the outline, and the cavity must be put into the self-cleansing area, can be cleaned easily by the patient. This is caries and undermined enamel must be weak, friable, undermined enamel. Must be removed. Or if it is undermined enamel, it is not weak and it is not friable, it is slightly stiff enough. So in case of bonded restoration, we have to leave it. Avoid stress concentration or stress concentration. We are not to extend the outline to the area of the stress. The second thing we have to do, that is the harmonious sweeping curves for the outline of the cavity must be sweeping curves, okay, with the roundation, so the stress will be not concentrated, so the restoration and the tooth cannot be fractured. Our internal outline, or for example, for the amalgam and for the ceramic must be rounded to reduce stress, to prevent fracture, either to, if it is amalgam or if it is indirect restoration, ceramic will be prevent fracture. Only for gold inlay we leave that outline to sharp outline to easy packing of the foil or condensing of the gold foil into the cavity. Okay. The shape of the cavity must be at the right fold. It is inverted truncated cone. It is 5 to 6 degree convergence between the buccal and lingual wall of the cavity. As the crown bridge, it is 5 to 6 degree convergence between the buccal and lingual. It is the same, and outside the side, and the medial and distal wall must be parallel because the direction of the enamel prism into the medial and distal parallel, not into the inclined position as in the occlusal cavities. Cavity approaching each other, two cavity approaching. If it is less than 0.5 millimeter, and for amalgam we have to make it one cavity. If it is for example for adhesive restoration, so we leave this area, sound tooth structure 1 or 2 involved into the cavity, and bring the adhesive restoration to join our two, or to connect the two cavities, and to reinforce that remaining of our tooth structure by adhesive restoration. This is tooth structure. This is the situation which I cross weakening tooth structure when transfer stress also when they do as adhesive restoration, transfer stress into that between these and this side of the cavities. Reinforce the weak tooth structure by this. That I told you before. That is the adhesive restoration. We can join the two cavity and to reinforce these ridges and make stress concentration to make the fracture into the remaining part. It is not possible. Not possible. Extension for prevention. This is the old criteria. We cut through the immune area. For example, from the buccal, we extend from the buccal to immune area. That will compromise the aesthetic of the amalgam. So we have not to cut more to the lingua than to the buccal. Or if it is the case extended into that area, we have to cut to follow the case, and we put the restoration, adhesive restoration or aesthetic restoration as composite. At first, weakening of the sound tooth structure, if it is due cut for prevention, we have to follow all the bits and fissures and extend this area so the tooth will be weak, instead of cutting one side here and the side is out of caries and free from the caries. We leave it because sound tooth structure we are not able to cut. We do the harm. So we have instruments, small instrument, more adhesive and more strong material we put and static material. So we have not able to cut this because we cut audio over cutting. We are less conservative, and we have to be more conservative. Increasing in this stage, we're increasing the pulp because we are cutting into the area which the pulp is higher. So we are close to the pulp. Sometimes we invade the pulp. Increase the ability of recurrent. This area would be all the restoration, and the margin between restoration of the cavity must, during force or during mastication, sometimes this is weak area will break restoration and make the leaky gap and make the recurrent caries. Or sometimes the weak area will fracture and make the recurrent caries around the restoration or around the restoration, or the restoration will fracture and will be underneath there is a recurrent caries. Here, outline form. Agency. Obtaining the outline form. Definition. This is we do it here now. Factors modify what factor modify the outline? Age of the patient. We cut the cavity into the smaller age, so we have large bulb chamber. It is close the bulb horn near the surface, near the amyloid. There is little dentine between the amyloid-dentinal junction and the pulp. So we have to fear from the exposure. In the larger patient, to have the bulb will be receded, secondary dentine will be formed. So there is a sufficient amount of dentine between the amyloid-dentinal junction and the pulp. So we have to do this criteria. So cutting through the younger age, so we have to more conservative because we have to prevent the further damage of the patient of the pulp. For older patient, it is prevented by the thick dentine or secondary dentine. Also for the larger patient, there is during use the cusp will wear slightly and the grooves will be shallower, so the retention of the food and the material and possibility of caries producing caries it is less. So for this situation, we are not to extend the cavity into all the basement fissure, because there is only there is normal cleansing aid or physiological cleansing, normal physiological aid for the cavity, because the cavity is shallow due to the use of the function. But for the younger patient, we have either to do extend the cavity into a curved lesion, and if there is deep fissure and basement fissure, we have to do amyloplasty and to do fissure sealing. To do fissure sealing to make the cavity shallower and less retentive to the food. Oral hygiene must be instruct the patient for oral hygiene. If it is basement neglected oral hygiene, so we have to do the margin of the cavity out into the area of the self-cleansing. If it is good oral hygiene, so we have not aim to extend the cavity into beyond the limit, because there is self-cleansing, so we have not to do it in the self-cleansing area, because the patient will gain oral hygiene. Physiology of the restorative material. Some restorative material, it has reasons. So this restoration will join the tooth structure and reinforce the tooth structure, and will produce little bit of tooth structure. And if the case is in enamel, we have to do that, no problem with that restoration. Amalgam will need to put into the dentine, so it is the amalgam is brittle, so we have to make the outline, it is more rounded, and make the bulk of the amalgam or the bulky depth around not less than 2 millimeters of the thickness of the amalgam. So technique for construction. Technique for construction, we have what technique for the construction? It is we construct direct technique, direct amalgam. We have to do fated truncated cone. We have to do 5-2D conversion from the occlusal. We have to do flat bulbar floors. Okay, we to equalize the stresses. We have to do a roundation of line angle, roundation angle, which we have to do. K4 surface angle must be 90 degrees. This is the situation if it is for amalgam. For composite, never, because it is boundary restrictions to have either to make flat or more not flat. It is not. It is unnecessary, but if it is not, it is no problem. K4 surface angle for amalgam for composite, if it is out of stress area, must be baffled. But if it is in the stress area, we have to recommend to do baffled. Need for static. If it is static is needed, we have we have not exceeded to the in the premolar area, for example, upper premolars beyond the buccoaxial or buccomedial line angle or buccodistal line angle, buccoaxial line angles, and if it is exceeded, we have to do a static restoration or composite restoration. Conventional need, so we have to see the cavity. We have to be able to focus on the cavity. We need to see the cavity, the outline of the cavity by the naked eye easily, and to easily to put and apply the restorative material. Presence of weak cusp. If there is weak cusp, as we told you, that is, if it is the cuspal height is more than the cuspal width, so we have to do back of the cuspus. Okay. Dimension of the contact area. In buccolingually, the dimension of contact area, as you mentioned, it is more to the buccal for molars, and the dimension will be more. So we have to follow that criteria for the criteria of that buccolingual, because the contact area is wider buccolingually. Okay. Younger patient, as told, this ability to carry recurrence, it is high because deeper fissures and bits and fissure and grooves here. So will be ensured the region of the retentive must be retentive, and we have to reduce the risk by do fissure sealing or to do enameloplasty for the other part, which is not improved by cares. For older patients, we have the possibility of the recurrent cases low, because there is attrition and bus and fissure will be shallow. So enameloplasty cannot be needed because the cleansing area, self-cleansing, it is present. Old age of the patient. Old age of the patient. We have to start بسم الله الرحمن الرحيم. نبدأ الجزئية الثانية باش على الأقل احنا نحاول نجز الوقت متاعنا باش يسمح لنا البرنامج متاعنا شوي. Factors modifying the age of the patient, قلنا it is old age, young age, oral hygiene status, and material is braided material which need more bulk, for example amalgam to increase the compressive strength of the amalgam. Ductile material, if it is ductile material or not. Technique for construction, indirect constructed resuscitation material, gold inlay or ceramic. If it is cavity large, all we have to do indirect resuscitation more because it is bonded with adhesive resin cement and it is give strengthening to the two structures. Aesthetic need, ultra conservative outline must be done to when we more conservative, we more follow the aesthetic. Undermined enamel wall glass three caries should be left. So any undermined enamel in the glass three cavities from the buccal side so lifted because there is no suspected stress, so it is reinforced with the adhesive restoration. Gingival wall of glass 5 cavity, it is not extended more gingivally because it will less enamel, this bonding, recurrent caries will be high, so we have to do over the gingiva, not lower to the gingiva, and must be buried to the gingival floor, must be buried to the gingival contour. Okay, for example, here in the glass 5 cavities, so we have to follow the gingival contour from the cervical wall of the cavity, from the inside the wall of the cavity or inside the wall of the cavity or close the wall of the cavity must be give cracifial curve. This is follow the gingival contour. This is follow the cracifial curve. This is the outline which we needed into the glass 5 cavity for all these. So convenience for manipulation of the instrumentation or for the cleaning of the cavity, because now as I told you, this is a smaller instrument is present, so convenience it is only to have to see the caries visible, the caries complete visibility to completely removal, and to see the outline, and that's it for that convenience. Presence of weak cusp. Weak cusp that at this is the picture, it is close to gingival height more than the height more than width, so we have to do cusp capping to make the height equal to the width, 2 millimeters of the cusp capping. If 2 cusps, we have to do cusp capping, and we have to do only means it is capping or covering by the cusp restoration from the buccal or the lingual. Preservation of weak cuspes, so we have to preserve weak cuspes, cusp capping or cusp coverage for gold cusp, gold. Either cusp capping for amalgam or cap to amalgam to cover for reduce the cusp to 2 millimeters and fill with the amalgam. And if it is cusp gold, we have to cover the cuspes and do crown, or if it is bridge, we have to do bridge. This is in case of the weak cuspes, so we have 2 millimeters of the thickness we need it for cap of the cusp of the amalgam, or we have to do counter bevel here for cast gold. Dimension of the contact area, buccolingual width. The glass contact area determined as this is the contact area that it is the buccolingual dimension of the glass 2 cavity from the closure. It is the junction between the axial wall and the occlusal wall of the cavity. It is known as isthmus. This isthmus must be not so wide, so must be to ensure the retention and resistant form. If the widening impression show widening the the isthmus, so possibility to weaken the tooth structure and fracture of the restoration. And the axial-bulbar line angle must be rounded or must be beveled and round to reduce stress into that area, because it is the most famous failure into the glass tooth cavity is isthmus. If it is the isthmus, it is either narrow or wider, so it will make failure of the restoration. So we have to do the isthmus width is 1/3 of the buccolingual dimension of the tooth. 1/3 of buccolingual dimension of tooth, and not exceeded the 1/3 of the buccolingual dimension of the tooth to prevent weakening of the tooth and fracture of the tooth. And if it is narrower, it will also little material there and will make fracture and splitting of the material. This is the isthmus. So we have, when there is wider contact, we have to open the isthmus. But for aesthetic, we have open from the lingual side smooth, okay, and do that. We can reverse curve from the buccal and from the lingual. When we do, for example, aesthetic restoration, we have to do reverse curve from the buccal, and we do reverse curve from the lingual if it is wide contact. If it is narrow contact, so we have to follow that is a straight line, and not to do reverse curve. Reverse curve, it is from the buccal, and it will become around 135-degree angle. Okay, this is the reverse curve from the buccal. This is the and the straight curve from the lingual. This is the reverse curve from the buccal. To reach the self-cleansing area. This is the aim of the reverse curve, to put the restoration to the self-cleansing area, either from a straight curve here, to put the restoration into the self-cleansing area from the buccal, from the lingual, and from the buccal. This is uniform here, and this is uniform here if the contact is wide, if the contact is narrow, so it will be uniform here. If the contact is wide, so we have to do a reverse curve to put the restoration, or to carry the restoration to the self-cleansing area. Example for the upper molar. This is the oblique, which you have to know this. You have to know the anatomy of upper molars and lower molars. Anatomy of the tooth. Reverse curve requires buccal wall area rather than lingual wall. Contact area, because the contact area shifted toward buccal, so we have to do reverse curve into the buccal. So this is the point which I needed to know. The reverse curve, it is only in all the time, but from the buccal, neither lingual, because the contact area, it is more toward the buccal than lingual. Okay, because it is because there is self-cleansing area into the natural tooth. So the buccal embrasure, lingual embrasure is wider than the buccal embrasure. So when which makes the buccal embrasure is narrower, it is the contact area. It is more toward the buccal, So we have to do reverse curve. For reverse curve provide adequate required K4 angle 90 also conserve. Okay, so we'll give the 90-degree angle. So here the reverse curve give 90-degree angle, which gives 90-degree angle. So reverse curve will give 90-degree angle, which needs. Okay, K4 surface angle will give here, it is 90-degree. So the reverse curve will give 90-degree K4 surface angle. So reverse curve give 90-degree K4 surface line angles. نستمر تاني ان شاء الله، بس على اساس ان احنا باش نكمل نسجل المحاضره باش ما تكون مستمره افضل من هذه القطه. قلنا the reserve curves قلنا dimension of the contact area, occlusogingival height if the contact area affected the position of the gingival floor. So the gingival floor affected by occlused gingival height. If it is occlused gingival height is more for the contact area, the gingival floor will be more cervical of the cavity. If it is this occlusive gingivally, so the gingival floor will be more towards the occlusal. And when the contact area exceeds occlusive gingivally, so the risk for putting the gingival floor into maybe under the gingiva or over the gingiva will give risk for the gingival involvement and gingival inflammations and sometimes recurrent caries. If the occlusive gingival height of the contact area is small, so we are more in the enamel, so recurrent caries will be reduced and less harm to the gingiva because we are away from the gingiva. Okay. Mechanical principles. So in this area, the gingival floor, sometimes we do bevel. Or the gingival margin trimmer, we bevel. We remove any undermined enamel for all the teeth. For younger teeth, because the enamel is here nearly barrel, so not to do bevel. For the elderly teeth or for adolescent or older age teeth must be do bevel because to remove any undermined enamel because it is moving like this way. So we have to cut this enamel here. Okay. Performing resistance and retention form, we have to stop here into the performing resistance 2P1 and we have to and then have to السلام ورحمة الله.